So welcome back again to the second part of cell injury, cell death and adaptations lecture. During this lecture, we will discuss the patterns of cell injury, reversible and irreversible cell injury, their morphologic and ultrastructural alterations in the affected cells, and the different patterns of necrosis type of cell death. So let's start with this very important illustration regarding the cell injury and different types or patterns of cell death. You can see here the normal cell with its normal organelles. When the cell is exposed to a stressful event or any injurious stimulus, the cell first, if it cannot adapt, will go into the reversible cell injury, in which if the injurious stimulus is removed or disappears, the cell can still go back to normal. These reversibly injured cells are non-functional. They lose function as early as possible. So the first thing to be lost after cell injury occurs is the function of the cell. Then starts the ultrastructural alterations in these cells. So you can see here the main difference between this normal cell and the reversibly injured cell is the size of the cell. Here it's swollen زي البالون لما تنفخه بالهواء أو تحط فيه تعبيه مي راح ينتفخ، فهذا بنسميه swilling of the cell. And you can see that the plasma membrane of the cell is still intact. However, it is composed of these blips, and it is blunted with some microvillus architecture. So these blips are there, but the cell membrane is intact. And if you look at the size of the organelles inside the cell, like the mitochondria, the endoplasmic reticulum, these are swollen. Swelling of the endoplasmic reticulum, swelling of the mitochondria with appearance of microdensities inside them, in addition to the accumulation of injured or damaged phospholipids inside the cell, which we call it myelin figures. Now, if this cell is exposed to much higher stress and a more severe injury, the cell cannot withstand the reversible injury and it undergoes a progressive injury in which cell death occurs. We call it here the irreversible cell injury or necrotic type of death. So in irreversible injury, it equals necrosis. The cell is dead and in preparation to disappear. So you can see the main differences here between the reversibly injured cell and irreversibly injured cells are the plasma membrane abnormalities. The plasma membrane is discontinuous, as you can see here. Discontinuities like rupture, like when you have a balloon and you start to fill it with water or with air. When it exceeds the limits of the limited capacity to of its size, it will rupture. That is the cell death or the necrosis. The cell will rupture. بتضلها تنتفخ لحتى تنفجر. So these look at the mitochondria, the endoplasmic reticulum are still swollen, and we start to see changes in the nucleus. Here we will discuss it later when we talk about the changes and the ultrastructural changes in necrosis. And here the inflammatory cells, they come to the area in order to engulf and eat and to digest these necrotic or dead cells. The other pathway of cell death is called apoptosis, and we will discuss it later in the next lecture. But you have to know that necrosis and apoptosis are two different patterns of cell death. Necrosis is called the uncontrolled type of cell death, and apoptosis is called the programmed or controlled type of cell death. Now let's start with reversible cell injury. From its name, if the damaging stimulus is removed, the injured cells can return back to normal. وأهم إشي شفتوه في الصورة اللي قبل هو إنه البلازما membrane is still intact والorganelles are swollen but they are still there, they are not ruptured, they are not damaged, and the nucleus is almost altered in a very minimal way. Now the cell can go back to normal, but during the reversible injury it can undergo certain changes. Now remember always that an injured cell, whether it is reversible injury or irreversible injury, the function is lost. But in reversible injury, the cell is still alive. بينما بالirreversible injury, the cell is dead. خلية ميتة. بالreversible injury في عنا certain changes بنسميها morphologic alterations، يعني كيف بيتغير شكل الخلية. المورفولوجيك alterations اللي بتصير طبعا تاخد وقت عبين ما تصير، مش immediately. المورفولوجي احنا ممكن نشوفه at the light microscopy level بالمصباح الضوئي العادي، وممكن يكون at the electron microscopic level، وهي بنسميها ultra structural changes اللي هي عشان اشوف الاورجانيلز والسيل ممبرين. هاي الاشياء كلياتها بدها electron microscope. The main morphologic changes بالreversible injury هي cellular swilling and fatty change. Now, cellular swilling can be seen by naked eye as a swelling of the whole organ. So if the whole cells of the organ are swollen ومنتفخات، وبالتالي the whole organ is swollen with an increased size of the organ. Now at the light microscopic level إذا أخذنا biopsy منها injured tissue, like for example in this picture here you can see this is a section from the liver. The main finding is cellular swelling، الخلية منتفخة. فهدول الخلايا الهيباتوسايتس اللي البياض whitish color in the cytoplasm is increased. This corresponds to appearance of water inside the cytoplasm. ليش بصير cell swelling? Because of the inability of the membrane pumps to function. لأن الخلية اللي بالreversible injury بتكون non-functional، فبالتالي الصوديوم potassium pumps in the membrane are non-functional، وبالتالي بصير عندنا يدخل الصوديوم inside the cell ويسحب معاه water، فالnet result is increase in the size of the cell and swelling due to water accumulation. That's what we call it hydropic change or cellular swelling، وبنقدر نشوفه بالlight microscope. The other morphologic change في reversible injury هو fatty change، وزي ما حكينا again ممكن نشوفه على شكل macroscopic appearance اللي هو بنشوفه بعيننا. This is the liver in a reversible injury. شوفوا كيف الكلر نتيجة الفاتي change بتحول لونه للون الأصفر نتيجة accumulation of fat. And the microscopic appearance اللي هو بنشوفه under the light microscope with the appearance of these fat droplets. طلعوا كيف شكله زي الاديبوز tissue. These are fat droplets inside the injured cells. ليش بصير fat droplets? Due to the accumulation of damaged phospholipids from the injured cell membranes and organelle membranes. So when they accumulate in the cytoplasm, they give us these fatty droplets. At the electron microscopic level, we have other changes that cannot be appreciated by macroscopic and microscopic appearance. We need more detailed studies to see these changes at the level of the organelles. We need the electron microscope. The main changes in reversible injury are plasma membrane alterations in the form of blipping and blunting. But remember here that the plasma membrane is still intact, بس منتفخ. Mitochondrial changes characterized by swelling of the mitochondria or appearance of black densities or dark densities of damaged phospholipids inside the mitochondria. Also, the endoplasmic reticulum is swollen and dilated. The nuclear material in the chromatin in the nucleus اللي هي اللي بنسميها الchromatin is clumped. We call it nuclear clumping. And we have also appearance of the cytoplasmic myelin figures derived from the damaged phospholipids from the cell membranes and organelle membranes. So the nucleus is still there, the membrane is intact. When the injurious stimulus disappear, all of these changes can be reversed back to normal and the cell goes back to normal. Now, if the injury is very severe or prolonged, or the cell cannot withstand the reversible injury, it will enter into cell death, or what we call it irreversible injury or necrosis. The main characteristic features of necrosis at the ultrastructural level of the cell is irreversible mitochondrial dysfunction. This feature characterizes the irreversible injury because the mitochondria, it's the main energy factory of the cell. So when we cannot restore the mitochondrial function back to normal, so the cell is considered dead. The second main ultrastructural level is the loss of plasma membrane and intracellular membrane integrities. This will lead to rupture of the plasma membrane, discontinuities in the plasma membrane, and rupture of the intracellular membranes like mitochondrial membranes, leading to mitochondrial dysfunction, for example, and the lysosomal membranes, leading to rupture of lysosomes and release of the lysosomal enzymes into the cell. So the enzymes will leak into the cell and out of the cell, and this will lead to cellular loss. Also, one of the ultrastructural changes in irreversible injury, loss of the DNA and the chromatin integrity، بحيث إنه ال DNA material is lost, it disappears، فبالتالي مستحيل, it's impossible for the cell to get back to normal. Now, the necrotic cells, these dead cells, they will stimulate an inflammatory reaction in order for the inflammatory cells to come and clean and clear the necrotic and dead cells and remove them as a preparation for repair. So what are the morphologic changes in irreversible cell injury? We can see again the morphology can be appreciated by macroscopic or microscopic appearance, or at the ultrastructural level by the electron microscope. The first thing that we see is increased cytoplasmic eosinophilia as opposed to the increased cytoplasmic water content in reversible cell injury. Because we said that in a reversible cell injury, the cell is swollen, the cell is filled with water. Under the microscope, we can see hydropic change and whitish color of the cytoplasm. بينما بالirreversible cell injury بصير عندنا increased cytoplasmic eosinophilia. Eosinophilia, this is after staining the slide with the hematoxylin and eosin stain اللي احنا بنستخدمها في البيسك stain اللي بنستخدمها في الهيستوباثولوجي. فالسيتوبلازميك ايزونوفيليا بتزيد لانه بيرتبط الايزون اكثر بالديناتشرد بروتينز اللي موجوده في السيتوبلازم، صار في عندنا بروتين ديناتشوريشن، وبرضه الار ان اي اللي موجود في السيتوبلازم بيختفي، وهذا هو بيعطي شويه بيزوفيليا ولون ازرقاق للسيتوبلازم. so الايزونوفيليا of the cytoplasm will increase لهدول السببين. بالإضافة إلى ال other changes اللي كانت موجودة في ال reversible injury, it will stay in the irreversible injury and it will be more severe, like marked dilatation of the endoplasmic reticulum, marked dilatation of the mitochondria with loss of mitochondrial and endoplasmic reticulum membranes, mitochondrial densities, more myelin figures will accumulate because of the more damage to the plasma membranes and organelle membranes. Now, the nuclear changes are very important in irreversible injury. It starts by pycnosis, which means shrinkage and increased basophilia of the nuclear chromatin material. فبالتالي the nucleus, it looks like a very darkish, very dark, very blue spot inside the cell. After that, the nuclear material or the chromatin material may undergo fragmentation. We call this karyorrhexis. And after this, sometimes the chromatin material will disappear. We call this coagulasive. The basophilia fades, so you will not see the nucleus anymore, and most likely this is as a result of the DNase. It's the enzyme that will dissociates or the DNA material. So all of these changes can be seen in irreversible cell injury, and here the cell will no longer is no longer able to get back to normal because all of the structural units of the cell are lost. So you can see here at the microscopic level, this is a section from the kidney to compare the normal kidney tubules with the reversibly injured tubules and irreversibly injured tubules. Normally, you can see here the cells with the nucleus inside. Here in reversible injury زي ما حكينا the main change هو cellular swilling and the hydropic change. فمعظم الخلايا فيها الوايتش vacuoles high inside the cytoplasm corresponding to increased amount of water. Now, some of the cells will have some increased eosinophilia as a preparation to enter into the irreversible cell injury, in which you can see here the cytoplasm is very eosinophilic in some cells, and some cells have lost their nucleus at all, and they are ruptured and lost. So this is the order of changes from normal to reversible injury to irreversible injury. So after discussing the two types of cell injury, reversible and irreversible, it is important to remind you again that the cell death can happen in two mechanisms. Different mechanisms depending on the nature and the severity of the injury. We have the necrosis type of cell death and apoptosis type of cell death. Necrosis usually happens when the injury is rapid and uncontrollable and leads to severe disturbances in the cells, most commonly due to ischemia, for example, toxins, سموم, infections, and trauma. So cell death occurs in these situations by the pattern of necrosis. The other pattern, which is apoptosis, usually is more controlled, more regulated by genes and signaling pathways, and usually happens when the injury is less severe, like, for example, sun-induced injury, growth factor deficiency, for example, and we can use the pattern of death by apoptosis. We can modify it by certain drugs, for example. It's the basic mechanism by which some of the chemotherapeutic agents work to treat certain types of cancers. So it's more controllable and it's more regulated. Now, in certain conditions, both necrosis and apoptosis occurs at the same time. We call it necroptosis. Like, for example, sometimes in ischemia, we can find the most of the cells die by necrosis. However, some cells may die also by apoptosis as a result of ischemia. This table is very important. It characterizes the main differences between the two main patterns of cell death, the necrosis and the apoptosis. We will discuss apoptosis in later lectures, and I will put this slide again just to compare between them. But let's review the main features of necrosis. Necrosis, the cell size is increased due to swelling of the cells. The nucleus will undergo changes from pycnosis to karyorrhexis and to karyolysis. The plasma membranes, as I said, are disrupted, discontinuous. The enzymes will leak out, and the lysosomal enzymes also will leak out, leading to digestion, enzymatic digestion of the cell. And after necrosis, the inflammatory cells will come to the area frequently in order to clear and phagocytose and ingest the necrotic cells and necrotic debris. من الجدير بالذكر إنه النكروسز is almost always pathologic. ما في شيء اسمه physiologic necrosis because necrosis is the end result of cell injury, irreversible cell injury. But when we come to apoptosis, and you will see in the lecture of apoptosis that the cell size is reduced, there is cellular shrinkage, and the nucleus will undergo fragmentation into small size fragments. The plasma membrane is intact، وهي شغلة كتير مهمة في الapoptosis إنه ما في disruption of the plasma membrane والcellular contents بتضلها داخل الخلية وintact وما بصير release or spillage to the outside, so there will be no inflammatory cells in the area. Maybe just few macrophages will come to digest the few apoptotic cells, but there will be no marked inflammation like in necrosis. Apoptosis also can be physiologic and can be pathologic, and we will talk about them in details when we come to apoptosis. Now, what are the clinical implications of cell injury? Why do we study cell injury? Why we have to know about the mechanisms or the sequence of events in cell injury? Because it helps us diagnose certain types of diseases. Because as you know, the leakage of intracellular proteins and enzymes from the damaged necrotic cells to the outside and which they ultimately reach to the circulation, to the blood, it provides us with a means of detecting tissue-specific necrosis using a blood sample or a serum sample. Like, for example, when we suspect a myocardial infarction or a myocardial muscle necrosis, the cardiac enzymes will leak out and will enter the blood, and we can detect them by laboratory investigations by cardiac enzymes measurement in the blood. Also, when we suspect a hepatitis, provided that we know that damaged hepatocytes by the hepatitis leads to spillage of hepatic enzymes into the outside of the cells and will enter the circulation, so we can measure the level of hepatic enzymes in the blood. When they are elevated, this means that there is a liver injury. Now, when necrosis affects a great proportion of the tissue or part of the organ, it will result in certain gross macroscopic appearances that we call them the morphologic patterns of tissue necrosis. These morphologic patterns that we see them by naked eye, by our eyes, we call them gross or macroscopic, can give us sometimes a clue about the etiology or the cause for the necrosis. All the morphologic patterns of necrosis can be seen grossly ما عدا الfibrinoid necrosis. It is only seen under the microscope. The first type of the morphologic pattern of necrosis is called coagulasive necrosis, and usually it is caused by ischemia to all solid organs except in the brain. It is characterized by a wedge-shaped pale area grossly corresponding to the blood supply of the organ, like you see here. It's pale-shaped, pale colored because of the loss of blood supply. يعني منطقة ما بيوصلها blood نتيجة الإسكيميا فبتصير اللون تبعها pale. Under the microscope, histologically, we have this also pale area, but what characterizes this pattern of necrosis is that the tissue architecture is conserved initially for certain hours or sometimes days because the ischemia will lead to denaturation not only of the proteins of the tissues but also to the enzymes. So there will be no enzymatic digestion. However, after hours or after a day or 2 days, for example, the rush of inflammatory cells and neutrophils and macrophages to the area to clear these nuclear eosinophilic cells. So the cells are eosinophilic with no nuclei because they are dead cells, but the tissue is architecture is preserved initially. لكن later on it will be digested or removed by the inflammatory cells that will come to the area. The second pattern of necrosis is called liquefactive necrosis. From its name, its liquefied area, like a viscous fluid-like material, appears on the affected area by this pattern of necrosis. Usually, it is caused by focal infections, whether bacterial and fungal infections, leading to this formation of a creamy yellowish fluid called pus, اللي هو العمل أو القيح. And it corresponds or caused by infarctions or ischemia to the central nervous system. As you can see here in the picture, we have a section here from the lung. So macroscopically or rigorously, we have this cavity containing yellowish fluid, and microscopically, it is characterized by the rapid accumulation of inflammatory cells, mainly neutrophils. This area, we call it an abscess or a liquefactive area of necrosis. Here in the brain, this is a focal area containing liquefactive viscous fluid, viscous material, corresponds to an area of infarction in the brain. Gangrenous necrosis is basically a coagulative necrosis, but it is a clinical term. يعني بنستخدمه كترم سريري أو ما يسمى بالعامية الجانجرين أو الغرغرينة. It is due to coagulative necrosis of tissues at different tissue planes of the organ. For example, here, this is the part of the distal limb in a patient who's most likely, those patients are diabetics with this diabetic foot. This blackish discoloration corresponds to the area of ischemic necrosis of the skin with underlying tissue and the bone. So it's at multiple planes, at different tissue planes. It can be dry or can be wet if there is a superimposed infection on it. The other type of necrosis is cassius necrosis. It is called like this because of the appearance of the cheesy like yellowish material at the area of cassius necrosis, like here, cheesy like material by gross examination. The tissue architecture is not preserved at all. It is completely lost. It is characterized by a center that is acellular with the cellular debris that is pinkish or eosinophilic, surrounded by macrophages and inflammatory cells and multinucleated giant cells. We call this structure granuloma. Most often, this type of necrosis is seen associated with tuberculosis. It is an important clue when we see cassius necrosis. The first thing that we think about is tuberculosis. Then we have the fat necrosis. Fat necrosis is usually associated with acute pancreatitis as a top emergency due to the release of pancreatic enzymes to the substance of the pancreas and to the peritoneum, pancreatic lipases, which will digest the fat that is present in the abdomen, releasing fatty acids from the triglycerides. So there is fat destruction. These fatty acids, when they are released, they can bind to calcium. They attract calcium, leading to the appearance of these calcified whitish foci. Here, they look like chalky material, and they help the surgeon and the pathologist to identify the fat necrosis. This is called saponification. So when the calcium is attached to the fatty acids, it is called saponification. Microscopically, we see the shadows of these necrotic fatty cells under the microscope. So fat necrosis, usually we associated or we first think of acute pancreatitis as the typical example. The last pattern of necrosis is called fibrinoid necrosis. This is only seen under the microscope, by light microscope, and it is characterized by the deposition of a fibrin containing pink material in the wall of the blood vessel, like you see here. This is the lumen of the blood vessel, and this is the wall, and there is accumulation of this fibrinoid material. The most Common association is vasculitis. This deposition is due to an antigen-antibody reaction in the wall of the blood vessel, like in vasculitis are autoimmune diseases characterized by inflammation in the wall of the blood vessel, leading to the deposition of this material.